Good morning. We're doing another video. This is another clinical case that I saw in the hospital 2 days ago, actually. And I like to do these videos because making the correlation from medical knowledge to clinical knowledge is a gap. And as a nephrologist, we deal with all kinds of sick people all the time. So I love to kind of help you guys see what we're doing in the background and behind the scenes with regard to how we manage these nephrology patients. I'm Dr. James Hall. I'm a nephrologist. I've been practicing about 20 years, and we're basically trying to teach you, the primary provider, how to do what we do. We're trying to bridge that gap because most nurse practitioners and physician extenders don't necessarily do a nephrology fellowship, but as a hypertension and nephrology specialist, we've done all that. And I tell you, working in the nephrology world is challenging, but I want to try to show you guys what we do, teach you guys what we do, so that you guys can see just have some transformation and be better adept at managing your patient population. Let's dive right in. This patient is a 64-year-old black gentleman who presented to the ER two days ago, short of breath. He was breathing about 30 to 40 times a minute. He was swollen. His legs probably had 2+ pitting edema. His serum creatinine was 3.2, and I'm sorry, his serum creatinine was, let me pull it up here, 4.2, and his GFR was 15. His serum potassium was 5.7, and his bicarb was 18. I'll review those labs again in a minute. But so we got a 64-year-old black gentleman presenting to the ER with acute kidney injury, or acute renal failure, as some people say. What do? When I first see a patient like this, my main concern is why. And this should be your concern as a primary provider. When you see an abnormal lab, don't just treat it. You see hypo or hyperkalemia, don't just treat that. Your question should be, why does this patient have a high potassium or low potassium? This patient had a potassium of 5.7. My question is why? Is it medication, ACE inhibitors? Is it aldactone? Is it Bactrim? Is it something that he's taking that's causing the potassium to be too high? Why is his bicarbonate level 18? Is it something he's doing that's causing it to be low? Is it something that you as a provider is doing that's causing his bicarb to be low? And his creatinine was 4.2. Why is his creatinine 4.2? What is his baseline creatinine? This guy's baseline creatinine was about 2, so it was 4.2, so it was double what it should be. His GFR was 15. His baseline GFR is around 35 to 40. So we need to figure out why. That's the magic question. And having the clinical experience and knowledge base to go with managing these patients when they come in the ER is what you're going to need. So what do? First of all, I look back at his old labs to try to see if he had any major CKD history. He didn't have any major CKD history, although he did have chronic kidney disease. He didn't have any nephrology appointments. He didn't have a nephrologist. He'd never really been worked up for chronic kidney disease. So what I did was I ordered a renal ultrasound, I ordered a drug screen, hepatitis, HIV, and kind of a serologic workup to see if there's anything else in the background causing this patient's creatinine to be so high, his GFR to be so low. Acutely, because he was so ill, we had to intervene, sooner than later. So we decided to put a dialysis catheter in him in the emergency room, and we decided to put him on dialysis. Since he was so hypotensive, his blood pressure was probably about 90/40 because he has cardiomyopathy and a pretty poor ejection fraction. We decided to go ahead and put him in an intensive care unit and start Prisma. Prisma is a continuous dialysis. It's really good for patients who are hypotensive, septic, and can't tolerate the large dialysis machine. I love it because, man, we can dial in exactly what we want real time. We can remove fluid, we can remove toxins, bring the potassium down. So in this patient, we got a dialysis catheter in and we started him on Prisma that night, and we removed about 100 to 150 milliliters of fluid per hour. Incidentally, his chest x-ray showed pulmonary edema. His oxygen saturation on presentation was around 89 to 90%. So he was fairly hypoxic on presentation. So this patient was ill. He was tachypnic, he was hypoxic, he was in acute kidney injury, he had fluid in his legs, and so, the ER doctor gave him some Lasix initially, but it didn't work. So by the time we got there, we decided to go ahead and do the dialysis. We removed about 1 liter to 1.5 liters fluid on him overnight, and his electrolytes improved significantly. His potassium came down from 5.7 to 4.4. His creatinine went from 4.2 to 3.2, and he was, I would say, 95% better after getting 1 night of dialysis. It was an amazing transition in watching how dialysis can actually treat your patients when they have something acute going on like this. So, like I said earlier, I'm Dr. James Hall. We've created this mini fellowship for primary care providers, and you can see the link below. There is a free webinar that I want you to check out that has a lot of cases like this in the webinar that we just dive in and deal with the clinical aspects of what you're seeing in clinic and in the hospital setting. I hope these case reports are really helpful because you can solidify your knowledge base and get the clinical background, clinical understanding of what to do when patients come in. Some of the topics we talk about are drugs and kidney disease, gout and kidney disease, ACE inhibitors and R's, when to stop, hyperkalemia, hypokalemia. So we talk about all this stuff using case reports, kind of like today in this case report. This patient actually has done well. He's still in the hospital right now. Hopefully he'll be going home because his renal function has improved significantly. His creatinine has improved. I'll tell you what his creatinine is. His creatinine is down to 2.7, and his GFR went from 15 all the way up to 25, and he's diuresing well. He's no longer hypoxic. He's no longer has pulmonary edema on his chest x-ray when you auscultate his lungs. And this was a really good case. The patient initially said, I don't want dialysis, I don't want dialysis. And I kind of scolded him because, he came to the hospital for a medical treatment. He was pretty ill, pretty sick. And I asked him, I said, well, why did you come if you didn't want us to do anything? It's kind of ironic you come to the hospital for us to treat you, but you refuse the treatment. So he decided to go ahead and do the dialysis, and that's really what he needed. I think he'll probably be fine without dialysis now that we got him out of the danger zone. One other thing that presented on his case in the emergency room, we did a bladder scan in the ER. He had around 800 milliliters of urine in his bladder. He has a past history of prostate cancer, so there could be an element of obstruction there. That's why you always get a renal ultrasound when any patient come in with acute kidney injury. They could be obstructed, especially if it's an older man. Always get a renal ultrasound because, they may tell you I haven't urinated a lot, and you may think just acute kidney injury or they haven't been drinking or dehydration. But I always, as a nephrologist, think obstruction, especially in men. So don't forget to get that renal ultrasound. That's going to be an easy, non-invasive procedure you can get to see if your patient's obstructed. A bladder ultrasound is good because it's bedside, it's real time. A lot of times the ER doctor, ER nurse can do that, and you can look in the bladder and see if it's full. That tells you that that patient's probably obstructed. There's a post-bladder obstruction that needs to be rectified. We placed a Foley catheter in this gentleman I'm talking to you about, and he immediately put out, like I said, about 700 to 800 milliliters of urine. So that was pretty striking. Hopefully, his obstruction will resolve. Most times we'll start something like Flomax, or one of those agents that can relax your ureters, relax your urethra, and allow fluid to come out. He doesn't have a prostate because he had a TURP done, transurethral resection of his prostate, but it will relax the prostate also if you have a prostate. So this is a really good case. I mean, there's a lot of different tiers to this case: acute kidney injury, hyperkalemia, acidosis, pulmonary edema, volume overload, obstructive uropathy. I mean, this case pretty much I could have come from all angles, and I think I tied it in well. We'll probably talk about it some more with all the information on the screen. I want to learn how to do that. If you guys can teach me how to do that, that'll be good. I would like to put my labs and x-ray and information on the screen while I'm presenting. That will help me and help you be able to just look at the labs and get a better understanding. So check us out below on our free webinar. I appreciate you tuning in to this video. We will see you next time. All right, bye.